Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome back to SummaryCast, where we break down the latest research in the world of imaging.
Today we're looking at a study that asks a really important question. We have a standard of care treatment for a common type of metastatic breast cancer, but we know it doesn't work equally well for everyone. What if an imaging scan patients are often already getting could tell us right from the start who is likely to have a better or worse outcome?
A prognostic biomarker hidden in plain sight. What's the paper?
This is Prognostic Significance of Pretreatment 18F FDG PET-CT Parameters in Patients with ER-positive, HER2-negative metastatic breast cancer treated with CDK4/6 inhibitors plus endocrine therapy. It was just published in the Korean Journal of Radiology in April 2026.
Okay, so ER-positive, HER2-negative metastatic breast cancer. The current standard is a CDK4/6 inhibitor combined with endocrine therapy. Why is a better prognostic tool needed here?
Because the treatment responses are, in the paper's words, heterogeneous. These therapies have been transformative, but approximately 20% of patients exhibit primary resistance, meaning they don't respond well from the get-go. And these aren't trivial treatments. They have side effects and are incredibly costly.
So being able to predict who won't benefit avoids unnecessary toxicity and expense. You want to get the right treatment to the right patient sooner.
Precisely. And this study's hypothesis is that a standard 18F FDG PET-CT scan performed before treatment starts can do that risk stratification.
There's a biological reason to think this would work, right?
There is, and it's quite an elegant connection. We know that FDG PET measures glucose metabolism. Tumors with high FDG uptake are often more aggressive. They have higher grade, higher Ki67, and so on.
That link is well established.
But it gets more specific here. The molecular pathway that drives up glycolysis, the PI3K ACT-mTOR pathway, is actually a known mechanism of primary resistance to CDK4/6 inhibitors.
Oh, wow. So a highly active PET scan doesn't just mean there are more targets for the drug to hit. It means the tumor is already equipped to bypass the drug?
Exactly. That hyperactive pathway ramps up glucose consumption and helps the tumor overpower the treatment. So a high PET signal isn't a green light. It's a biological warning sign that the patient might not respond well to the standard therapy.
Okay. I'm sold on the premise. How did the researchers test this?
This was a retrospective, single-center cohort study conducted at the Asan Medical Center in Korea. They looked at patients treated between 2018 and 2023.
Sample size, and what did this cohort look like?
They started with over 800 patients and, after exclusions, landed on a final cohort of 374. As for the demographics, the median age was 53. About half the patients, 50.3%, had visceral disease, meaning metastases to organs like the liver or lungs.
So, a population with a significant disease burden. Was this their first time being treated for metastatic disease?
For the vast majority, yes. 95.5% of patients received CDK4/6 inhibitors as a first-line therapy, which is the most common use case, so it's a very clinically relevant population.
Good. And what exactly were they measuring from the PET scans?
They focused on three key whole-body PET parameters. First, SUV max, the maximum standardized uptake value. In this study, that meant the single highest uptake value found anywhere in the entire scanned field across all metabolically active tumor sites, including the primary tumor, involved lymph nodes, and distant metastases.
The hottest tumor focus anywhere in the body. Got it.
Second was MTV, or metabolic tumor volume. They used a fixed SUV threshold of 2.5 to segment all the active tumor tissue in the body and calculate its total volume.
So the overall burden of active disease.
Exactly. And third was TLG, total lesion glycolysis. You can think of it as a combination of the first two. It's essentially the average SUV within the MTV multiplied by the MTV. It's a global measure of the body's total glycolytic activity from the tumor.
Okay, 3 different ways of quantifying metabolic burden. And what were the clinical outcomes they were trying to predict?
The primary outcome was progression-free survival, or PFS, the time until the cancer grew or the patient passed away. The secondary outcome was overall survival, OS.
And they used multivariable Cox models to make sure the PET parameters were independent predictors, not just proxies for other known clinical factors like tumor grade or visceral disease.
That's right. They adjusted for a comprehensive list of relevant clinical covariates, a very rigorous approach.
Let's get to it then. What did they find? Was there a signal?
There was a very strong and consistent signal across all three PET parameters. At a high level, the more metabolically active and widespread the disease was on the baseline PET scan, the worse the outcomes were for the patient. The median PFS for the cohort was 28.2 months, and the median OS was 57.9 months, which aligns really well with the pivotal clinical trials for these drugs.
That's a good sanity check. It suggests their cohort is representative. So let's dig into the numbers. What did the multivariable model show for the continuous PET values?
For progression-free survival, a higher SUV max was significantly associated with a higher risk of progression. The adjusted hazard ratio was 1.05.
So for every 1-point increase in SUV max, a 5% increase in the hazard of progression or death. That's a clear signal, but maybe not a huge effect size on its own.
Fair, but the volumetric metrics, MTV and TLG, showed an even stronger association. Because their distributions are skewed, they were log-transformed. For every 1 unit increase in log-transformed MTV, the hazard ratio for progression was 1.16.
A 16% increase in hazard. That's more substantial. Why do you think the volumetric metrics were more powerful than just the peak SUV?
It's a great question. SUV max reflects just a single voxel, the hottest point within the patient's overall tumor burden, so it captures the most metabolically active focus, but not the total extent of disease. A patient could have one very hot but small lesion, whereas another patient might have dozens of moderately active lesions spread throughout their body. MTV and TLG integrate all of that information into a single number.
So they provide a more global assessment of the disease? Did this hold true for overall survival as well?
It did, and the effect was even more pronounced. For overall survival, the adjusted hazard ratio for SUV max was 1.08. For log-transformed MTV, it was 1.24. And for TLG, it was 1.22.
So for every 1 unit increase in log-transformed MTV, there was a 24% increase in the hazard of death. That makes it a strong, independent predictor.
Yes, it is. And to make this more tangible, they also analyzed the data by dichotomizing the patients into high and low groups based on the median value for each PET parameter. This is where you can really see the separation.
Right. Looking at the Kaplan-Meier curves. What did they show?
They showed a very clear and early separation. For example, looking at the progression-free survival curves for TLG, the high TLG group starts to do worse almost immediately, and the gap between the two curves just widens over time. The log-rank p-value was 0.004.
A highly significant visual separation. What were the hazard ratios for this high versus low analysis?
After adjusting for other factors, patients with a TLG at or above the median of 78.9 had a 51% higher hazard of disease progression. The adjusted hazard ratio was 1.51.
A 51% increase in hazard, that's not trivial at all. And for overall survival, that same high TLG group?
The hazard ratio rose to 1.73, so a 73% higher hazard of death compared with patients who had a lower metabolic burden at baseline.
Wow, that is a very strong signal. So the bottom line from the results is that this common imaging test, performed before treatment even starts, contains significant prognostic information that's independent of other clinical variables.
You nailed it. It gives a snapshot of the tumor's metabolic phenotype, and that phenotype appears to be strongly predictive of its future behavior on this specific class of therapy. This study is also the largest to date to show this. Previous studies were much smaller and often focused on second-line therapy. So this work in a large, first-line cohort is a major step forward.
Which brings us to the next logical question. How could this actually be used in practice? What are the clinical implications?
That's the exciting part. This opens the door to risk-adapted strategies. Current NCCN and ESMO guidelines view PET-CT as complementary to conventional imaging. These findings argue it could be essential for decision-making before starting therapy.
How so?
For a patient whose pre-treatment PET scan shows very high MTV and TLG, you would immediately classify them as high risk. This knowledge could change management.
In what way? More frequent follow-up imaging?
That's one possibility. Perhaps earlier restaging at, say, 3 months to catch early progression, but you could also think about alternative treatment strategies. The paper mentions ongoing trials for triplet therapies, combining CDK4/6 inhibitors with agents targeting pathways like PI3K.
So PET could become the biomarker to select patients for those more intensive upfront combinations.
Exactly. On the flip side, what about the patients with very low metabolic burden on their PET? Does this open the door for de-escalation?
A really interesting thought. Could you spare them the toxicity and cost of a CDK4/6 inhibitor up front?
It's speculative, but important. The Sonia trial, for example, suggested that using CDK4/6 inhibitors in the second line versus the first line didn't change overall survival. Perhaps patients with a very favorable metabolic profile could safely start on endocrine therapy alone, reserving the CDK4/6 inhibitor for later. This biomarker could help identify that low-risk group.
That would be a major shift in practice. Okay, this is all very promising, but we need to talk about the limitations. Let's pressure test this. First and foremost, this is a retrospective single-center study.
Correct. That's the big one. Being at a single high-volume academic center often means you have very standardized treatment protocols and a specific patient referral pattern. We don't know for sure if these exact hazard ratios would hold up in a more diverse community oncology setting.
Right. The findings absolutely need to be validated in a prospective multi-center trial before they can be adopted as a standard of care. And this brings up the fundamental challenge with using PET parameters like MTV and TLG quantitatively: scanner variability.
Yes, this is a critical hurdle. To their credit, the authors were very aware of this. They harmonized the SUV profiles of their 3 GE scanners and completely excluded scans done on their Siemens machines because they had different profiles.
Which is good research practice, but it highlights the real-world problem. A patient might get their baseline scan at one facility and follow-up scans at another. Getting consistent, reliable MTV and TLG measurements in that environment is spiky.
It's the key challenge. Widespread adoption of a biomarker like this would require strict adherence to harmonized acquisition and reconstruction protocols like those developed by EANM/EARL. It's an engineering and logistics problem as much as a clinical one.
And the choice of segmentation threshold matters too. They used an SUV of 2.5, which is common, but different thresholds would produce different MTVs.
Another great point. It all comes back to the need for rigorous standardization if these quantitative metrics are to leave the research realm and enter routine clinical practice.
Let's land this. If I had to distill the takeaway, it's that this study provides compelling evidence that pretreatment 18F FDG PET-CT is much more than just a staging tool in this setting.
I think that's a perfect summary. It's a powerful, independent prognostic biomarker.
The intensity and, perhaps more importantly, the total volume of metabolic activity on that baseline scan can effectively stratify patients into different risk categories for both progression and survival.
Right. It suggests that the metabolic state of the cancer at baseline is a fundamental determinant of its response to CDK4/6 inhibition.
But the path to routine clinical use is clear, and it's a steep one. It requires prospective validation in diverse populations and, critically, solving the technical challenge of standardizing quantitative PET measurements across institutions.
A really clever finding that uncovers potential hidden in our daily work, but one that comes with a non-trivial set of engineering and implementation challenges to unlock its full value.
It seems the imaging gives us a clear look at the problem. The next step is building the systems to use that information reliably.
Well said.
That's all the time we have for this edition of SummaryCast.